The RESIST criteria you described very accurate. Is the, let's say, the common work, oncologic imaging radiologists, daily work. But as you said, we might have an unchanged diameter, long axis or short axis of a metastasis, which is actually necrotic inside. That means that perhaps with perfusion we can see that there is a very well response to the chemotherapy. But if we keep only the measurements, then we say perhaps it's not a good response. So just the RESIST criteria alone are not enough, I think. Or what do you think about that?
Yes, I totally agree with you. Today the RESIST 1.1 are not enough to determine the response.
Just a moment, we have a problem with the sound. Please repeat. Please repeat.
Can you hear me? Can you hear me now?
Just a moment, please.
Yes.
Επειδή έκανα την αλλαγή πριν με το presentation, δεν ακούμε στην αίθουσα. Ακούνε όμως όλοι. Can you please repeat?
Okay, now can you hear me? Can you hear the voice?
No, just a moment. Εγώ δεν τον ακούω, δώσε μου το. Okay, please try, repeat.
Okay, now?
Okay, I can hear you through the phone.
Oh, okay, perfect. I totally agree with you. Today, not to use only the RESIST 1.1, and the kind of response depends mainly on the kind of drug we use to treat the tumor. Because in clinical practice, we do not have only the standard cytotoxic, we do not have only immunotherapy, but we have also the anti-angiogenetic drug. So theoretically, we should combine the RESIST 1.1 with other functional technique in order to have a most complete overall assessment of response. So it depends on the center experience, it depends on the state of the art technologies that you have to work, and you should combine functional information with the standard brightness information. So measurement and functionality through cellularity and perfusivity. This is my suggestion, and it depends also on the clinician. You have to work together to create something more complex but more efficient for patient assessment.
Great, thank you very much. Thank you very much. I would like to ask now if somebody from the audience has a question.
May I ask a question to Professor Ippolito?
Professor Prasopoulos would like to ask you something, but just a moment, we have a technical problem. Please wait. Δεν γίνεται αυτό το πράγμα. Επειδή άλλαξες πριν. Can you hear us?
Yeah.
Okay. Professor Prasopoulos would like to ask something.
So, Professor Ippolito, I would like to thank you for being with us, and also I would like to thank you for this very constructive overview of the criteria to assess the response to treatment in patients with immunotherapy. As you have already told us, there are some trends to incorporate functional information and also information for perfusion. There is also some other information that radiology can provide, for example, information from texture analysis. Yeah. I would like to ask you why radiologists are not able to persuade the scientific community to adopt earlier such information, because radiology, it's much more beyond measurements. It's, as you already said, functional imaging, perfusion imaging, texture imaging analysis. Why we are not able to persuade the scientific community to adopt earlier such information, which is available? It's available from years now. It is an inability of radiology, or what other?
Thank you very much for a really interesting question. I think that today we have a great problem with the standardization of the technique. We could offer perfusion information, we can offer text or analysis, but to offer this kind of information, first we need more time. So the process that may cost more, both for clinician and for our routine daily work. Moreover, unfortunately, regarding the text or analysis, each different software, different CT scanner or MRI scanner, or each different acquisition protocol offer different information. So first of all, we have to standardize this kind of results in order to offer something that could be significant for our oncologist or referring clinician. My suggestion, like in our hospital, if you have this possibility, you can offer this kind of information, but they can be reliable only for your center. Till now, we have a wide range of application, but unfortunately, each center uses different technology, and so the final result not can be so simple to accept from referring clinician. But sure, we have to work together in this way. I think that also the artificial intelligence help us in that.
Thank you very much. Is there any question? Any other question from somebody from the audience? Please unmute yourself and ask the question if there is one.
Yes. Yes. Do you hear me?
Yes.
Yes. Yes.
I'm Lucas Dagdilelis from Papanikolaou Hospital. Just a specific question to Dr. Ippolito. Am I here? Okay. You mentioned that we do not count peritoneal carcinomatosis in target lesions. Okay. What if we have a peritoneal carcinomatosis lesion that is strictly solid and nodular? In that case, can we count it as a target lesion? A nodular, just one solitary and nodular peritoneal lesion. Do we count that as a target lesion? Can we count that as a target lesion? It's a special category, you know, from the real world.
Yes. Yeah. Okay. Thank you again for the question. I agree with you, but unfortunately, according to RESIST criteria, we cannot measure this, we cannot offer this measurement to assess correctly the response. And for this reason, I suggest in clinical practice to offer two different reports. In the first part, you can make a brief resume of target lesion, and then you should offer later in the second part all of the other side alteration, all of the other collateral alteration like carcinomatosis and so on. It's a problem because usually the peritoneal carcinomatosis and the solid component are not measured in the same way regarding the different radiologists, because we do not have any specific guidelines. Some of us measure just only one lesion, others measure confluent, so more than one, or other prefer to achieve the overall volume, but it's not so simple. So for this reason, I suggest to use the RESIST 1.1, summarize the 5 or 4 or 3 target lesion, and then offer further information regarding all of the other radiological findings.
Thank you.
Thank you, Lucas. So any other questions from the audience? Okay, if not, we can move to the second presentation and we discuss it again when it's finished. Thank you, Davide. We move now to the second one.
Thank you again. And let's move to the second presentation entitled CT and MR imaging in the functional assessment of HCC, from diagnosis to treatment response. Well, As we know, the HCC lesion represents the 6th most common cancer worldwide, with a 5-year survival rate less than 20%. And usually, the development of HCC lesion underlies some chronic liver condition due to the HB infection, HCV infection, or alcohol abuse. So the cirrhotic alteration represents the mainstay for development of hepatocellular carcinoma. And during the hepatocarcinogenesis, a spectrum of nodules may develop within the liver parenchyma, including benign regenerative nodule, dysplastic nodules, and HCC. And these nodules may be characterized by significant differences in terms of their respective blood supply. Because the regenerative nodules, like the liver parenchyma, continue to receive a majority of their blood supply from portal vein, while the high-grade dysplastic nodules and the early HCC is associated with a progression toward an increasing of arterial blood supply. On this basis, the hemodynamic changes can be well depicted during the multi-phase contrastographic computed tomography scan and during the magnetic resonance imaging, and usually both European and American guidelines have endorsed this technique for the diagnosis of HCC lesion with the maximum diameter more than 10 millimeters, based on the typical hallmarks represented by the hypervascularity during the arterial phase with washout during the portal venous or delayed phase. In this way, we can be able to avoid any possible liver biopsy. But unfortunately, there remains a high rate of false negative, ranging from 25 to 30%, in particular for those nodules with diameter less than 2 centimeters, which actually are the most often encountered focal liver lesion due to the widespread of surveillance program. Therefore, new technique that can be able to assess or to determine the tumor vascularity is highly desirable in order to offer further information for the correct characterization of hepatocellular carcinoma lesion in early phase. While regarding the treatment, according to BCLC guidelines, the hepatocellular carcinoma can undergo several treatment options according to the staging, so according to the number of hepatocellular carcinoma lesion, according to the maximum diameter, or to the presence of distant metastasis. But we should include also the clinical condition. And the goal of treatment is to determine the tumor necrosis and control the tumor growth while preserving as much functional liver tissue as possible. Moreover, patients with HCC that not respond to treatment may benefit from different treatment, while patients with partial response can be retreated. Therefore, an accurate, non-invasive method for both quantitative and qualitative analysis of tumor would be highly desirable. Because the treatment response in HCC, also when we use the target therapies, can be different from that we observed with conventional cytotoxic chemotherapy in solid tumor. Because again, the patient may experience an increase in size, decrease in size, may experience a stable disease, but we can also find a decrease in vascularity with or without significant change in size. We can find out a cavitation with stability in size, or we can also appreciate a cystic changes with or without decrease in size. Moreover, the changes in tumor volume after therapy do not necessarily correlate with true response to therapy. And for this reason, the traditional evaluation criteria that are based on tumor size like the WHO or the RECIST criteria are no longer effective because necrosis and cavitation may develop with no change in tumor size. Therefore, new evaluation criteria based on not only on tumor size but also on tumor enhancement that express the viable tumor tissue or the necrosis called modified RECIST or υγείας criteria have been suggested to assess the tumor response after treatment. And these criteria are based on the sides of viable tumor tissues, recommending to measure the longest and the shortest diameter of tumor enhancement during the arterial phase of dynamic study, both with CT or with MR. But we should achieve some limitation because the vascular changes can happen long before there is any evidence of tumor volume variation. Moreover, the unidimensional or the bidimensional measurement of irregular tumor does not accurately reflect total tumor burden. Moreover, the intra and the inter-observer variability of unidimensional measurement for irregular and poorly defined target HCC lesion can be an important limitation. So, given this limitation, today it is essential to couple the conventional morphological analysis with novel functional diagnostic tools in order to detect the early change modification and to predict tumor response. On this basis, it seems that the neoangiogenesis phenomenon, HCC related, that is the tumor-associated arterial neovascularization, plays a central role in the growth of tumor but also in the relapse of the disease. Therefore, through the new technique, we can try to evaluate the neoangiogenesis phenomenon to obtain information both about diagnosis in very early phase and both regarding the treatment with different possible technique. The functional imaging using multi-detector raw computer tomography or magnetic resonance imaging are increasingly advocated for the assessment of tissue vascularity and tissue cellularity. And unlike conventional imaging, which usually is reported qualitatively based on the varied brightness of tissue, the functional imaging technique offers quantitative data, numerical data, that can be easily incorporated into routine examination strictly related with the tissue perfusion and tissue vascularity, but also with tissue cellularity. So now we are able to look deeply inside our images in order to find out further information that are already present in our standard technique. Let's start with the perfusion CT technique. The principle of perfusion CT is based on the temporal changes in tissue density following the intravenous administration of iodinated contrast media. Later, the rate and the pattern of contrast enhancement reflects the time evolution of the contrast agent within the tissue, which occurs as a result of the microcirculatory pathophysiological changes. So, by the rapid sequential acquisition of imaging during the path of contrast in the tissue, perfusion CT may allow the quantification of tissue vascularity. And to better represent in clinical practice, usually we analyze a standard volume of liver. We acquired a sequential CT imaging with dynamic approach. Then our raw data will be analyzed by using a dedicated software which will create a quantitative map of arterial and portal perfusion by means of color scale. Then, from our color scale map, we can derive some different perfusion parameters, like the blood flow that express the tissue perfusion, the blood volume, the time to peak, the mean transit time, or arterial and portal perfusion for liver parenchyma. And this parameter expresses the total amount of blood contained for 100 gram of tissue, or it expresses the flow inside 100 gram of tissue and can differentiate the time to reach the maximum media concentration at specific level, or allow us also to differentiate the amount of arterial perfusion inside the liver parenchyma or inside the neoplastic alteration from those of portal vein perfusion. And let me show you an example of patient with huge HCC lesion in the left lower lobe that can be recognized on CT perfusion map like a green hotspot. Now, in our color map, we are able to draw a region of interest and compare the result of this area with those of healthy liver parenchyma. And here we can appreciate the significant increase of perfusion values as compared to cirrhotic one due to the neoangiogenesis phenomenon and due to the hypervascularization. that can be better expressed when we perform the angiographic study. We can recognize the arterial vascularization of the neoplastic nodule. Again, another example with the smallest HCC of 1.2 centimeters in the 8th segment of liver. Also in this case, the lesion can be clearly recognizable like a green hot spot on the CT perfusion map. Drawing the region of interest, again, we can compare the results between the neoplastic alteration and the standard liver parenchyma, expressing a significant increase of tumor vascularization. Also in this case, the angiographic study can confirm the nature of hyperarterial vascularization of neoplastic nodule. In this case, the patient was treated with transarterial chemoembolization, and we tried to use the CT perfusion technique to assess the response to treatment. And looking at the CT perfusion map, we can recognize this area of absence of tissue vascularity that finally was confirmed also by the quantitative perfusion map, in which we assist to a significant reduction of vascularization. And again, the angiographic study may allow us to appreciate the homogeneous deposition of lapiodol without any residual disease. But the CT perfusion technique can be applied also in case of patients with advanced HCC stage. Like in this patient, we can recognize a high amount of nodular neoplastic lesion at the dome of the liver, characterized by hyper-enhancement during the arterial phase, followed by washout in portal venous and in the late phase. Looking at the CT perfusion map, again, we can recognize this area of hot spot, characterized by significant hypervascularization if compared to surrounding cirrhotic parenchyma. In this case, due to the advanced stage of the disease, the patient underwent sorafenib treatment, that is an anti-angiogenic drug, and the first follow-up, looking at the maximum diameter or looking at the number of nodules, they still remain the same, but we are not able to correctly define the category of patient. Therefore, we try to apply the CT perfusion study that show us the significant reduction of brightness of the lesion at the liver dome, and as well the quantitative perfusion parameters allow us to appreciate the reduction of tumor vascularization if compared with baseline, while the surrounding parenchyma remained the same. So the patient were considered as a partial response, And this box plot summarizes our experience at the beginning when we compare the perfusion alteration in hepatocellular carcinoma, comparing the results with adjacent liver parenchyma, and we can appreciate the significant increase of perfusion, of vascularization of the total amount of blood flow and blood contained of hepatocellular carcinoma, while we can recognize the significant reduction of time to peak. That is the time to reach the maximum media concentration. And usually, the HCC present a high peak of concentration if compared to surrounding adjacent parenchyma. And the same kind of result was obtained also after treatment, both with TACE or with RFA, in which the residual disease showed a higher perfusion value compared to the region of necrosis or to cirrhotic parenchyma for all the evaluated parameters. And usually the cirrhotic alteration and the region of necrosis presented some similar values. But let's move to the perfusion MRI with another technique. The dynamic contrast enhanced perfusion MRI again is a non-invasive imaging biomarker which can provide measurable changes in tumor blood flow, vascular permeability, or in the interstitial and intravascular volumes. The basis, again, in this case, is the acquisition of multiple T1 weighted images every few seconds through the tumor or as much of the organ as possible after and during the gadolinium injection. Then the rate of pattern of contrast enhancement reflects the time evolution of the contrast agent within the tissue, which occurs as a result of the microcirculatory pathophysiological changes. And the final results will be expressed again as a color map of vascularization. But when we work with perfusion MRI, in a magnetic resonance domain, we have two possibilities to quantify the perfusion. We can apply a semi-quantitative method that it's very simple to apply, because usually we can use the standard 4 contrastographic phase in order to derive some semi-quantitative perfusion parameters. But unfortunately, it cannot offer us the absolute correct values of tissue concentration, of flow concentration, but it offers us only a percentage of value. On the other hand, we can try to use an absolute quantitative method that use different kinetic model. But in this case, we have to change our acquisition protocol, acquiring more than 10 contrastographic phase at single liver level. And so we should modify our standard acquisition protocol, missing the standard information regarding the arterial hypervascularization followed by washout. In this case, we can offer absolute quantitative value of vascularization. Obviously, this kind of application is a time-consuming and more computational demanding. Usually, the perfusion MRI in clinical practice has been used with both technique, semi-quantitative and quantitative, just to assess the response to treatment and to determine the changes in vascular permeability. And usually, the most important study was related to the application of sorafenib treatment that demonstrated that the perfusion modification was more evident in the early phase of the disease, just 2 weeks later after the treatment. And the K-trans was the most important parameter related to the response of treatment. Both works was performed by the group of Chen in South Korea, and they demonstrated that in the first phase, the K-trans well correlate with the response to tumor therapy. Moreover, they demonstrated in the other works that the baseline peak is an independent predictor for the overall survival of patients with HCC. So we can use the perfusion parameter also to discriminate between patients that will survive the treatment and from those that will not survive. Moreover, regarding the contrast agent administration on magnetic resonance imaging, to date, we have the possibility to use several hepatocyte-specific contrast agents, like the gadolinium AOB-DTPA, that is a liver-specific gadolinium-based contrast agent that allows the focal liver lesion characterization during contrast sequences based on lesion enhancement during the jamming phase as well as during the hepatocyte phase, because this contrast agent can accumulate itself inside the hepatocyte due to the presence of some carrier along the wall of the hepatocyte that usually are those carriers of the bilirubin. So the normal liver cell are able to accumulate and concentrate in hepatospecific phase the contrast agent, while the neoplastic cell that are no more any liver cell do not have any bilirubin carrier inside, and so they do not accumulate. Finally, the importance of this contrast agent is to allow to determine the functional liver tissues compared with those non-functional liver tissue, offering quantitative information and offering significant information also regarding the characterization of nodules inside the liver parenchyma, because as we said at the beginning of presentation, a lot kind of nodule may develop in cirrhotic patient, and usually the regenerative nodule that present a similar behavior to those of normal cell are characterized by hyperintensity in the hepatobiliary phase, because the hepatocyte can accumulate the contrast agent, while the high-grade dysplastic nodule or the early HCC or the HCC cannot concentrate the contrast agent during the hepatobiliary phase because they have no more carrier inside. And this contrast agent is also able to characterize a specific kind of hepatocellular carcinoma called green HCC, that is a well-differentiated hepatocellular carcinoma characterized by carrier of bilirubin inside, and so is green due to the bilirubin accumulation. In the same way, the contrast agent allow us to differentiate this kind of accumulation because the HCC presents the typical wash-in, the washout on portal venous and the late phase, but hyperaccumulation during the hepatobiliary phase. The different kind and the early diagnosis of nodular neoplastic lesion in liver is fundamental also for the better management strategy, deciding for follow-up or for possible treatment. Finally, another important application in MRI is represented by diffusion-weighted sequences. DWI is a functional MRI sequence that allows the characterization of biological tissues based on the diffusion properties of water molecules, providing information about tissue cellularity and integrity of cellular membranes. Because usually in high cellular tissue, we have a higher density of hydrophobic cellular membranes that reduce the apparent diffusion of water movement of protons. Thus, the water diffusion can be considered relatively restricted. So, in normal condition, the water molecules can move inside our area of analysis in a free way, while in case of a neoplastic lesion in which we have a high amount of tissue cellularity, the water molecules cannot be moved, and so the movement is defined as restricted. More simply, the diffusion restriction refers to a tumor signal intensity that is higher than surrounding liver parenchyma. Moreover, we can be able also to quantify the diffusivity of water molecules by using the ADC or apparent diffusion coefficient of water molecules. And usually higher is the value, more healthy is the tissue. Lower is the ADC value, higher is the amount of neoplastic cell inside. Therefore, we can also able to quantify the response to treatment or make the diagnosis of lesion according to the different apparent diffusion coefficient value. The diffusion sequences are really useful in clinical practice because they do not require any intravenous contrast media injection. They assess the diffusion of water molecules, the cellular density, and also the presence of necrosis. And we may be able also to obtain quantitative information through the apparent diffusion coefficient, and in therapy setting, it represents an index of tumor cell apoptosis and proliferation. And we know that these kind of sequences are already integral part of MR liver protocol. For this reason, there exists a lot of study about DWI in monitoring the response to oncologic treatment, such as the chemotherapy or the radiation, and all of them have reported an increase of ADC value during the therapy, which has been ascribed to the tumor necrosis and to reduction of tissue cellularity. But unfortunately, this was not the case of the patients evaluated after treatment with sorafenib. Why? Because usually the sorafenib in the early phase determine a decrease of ADC value in relation to the development of hemorrhagic tumor necrosis or ischemia. Subsequently, some months later, so not in the early phase, the value of ADC will increase in line with the response to treatment and in line with other neoplastic alteration. So the functional information provided by ADC measurement could be used as a marker for tumor progression only in the later phase of follow-up of HCC after sorafenib treatment. Moreover, do not forget that when we work with diffusion-weighted sequences, sometimes the value of apparent diffusion coefficient may present an overlap in the intermediate phase, so it not suggests to apply this kind of value in the early phase of the disease. Let's move to the most recent, the youngest application of functional imaging in CT, MR, and PET, that is called texture analysis. The texture analysis is an area of radiomics that extracts, analyzes, and interprets the quantitative imaging features that can be obtained among CT, MRI, and PET with 2D or with 3D technique. It allows objective assessment of lesion or organ heterogeneity, offering us some quantitative information that can be related to the tissue microenvironment. So the radiomics can be used just to determine the lesion characterization, offering us the possibility to distinguish the benign lesion from malignant ones. But how can texture analysis work? How can that provide information? Usually, it analyzes the distribution and the relationship of pixel or of the voxel in terms of gray levels. And we have different methods of texture analysis, including a statistical model, transform-based model, and so on. But the most applied in clinical practice is the statistical-based approach. This statistical method allows to identify the number of different pixels, how and where are they distributed inside the liver parenchyma, and the relationship between them. So let's move into the possible practical approach of texture analysis. First of all, we have to identify the lesion or tissue with CT, MR, or with PET. Later, we have to draw on a region of interest in manual manner or in automatic way. And then we should launch our texture analysis software that will offer us some statistical information that are called features. These features can present a different order. The most simple one, first order features, more difficult second order, and the most one in terms of difficulty of interpretation, the high order features. But the most used approach is the statistical model with the first order features. In a statistical model, the first order statistically evaluates the grade level frequency distribution from the pixel intensity histogram. And so we can evaluate the number of different pixels and the value of each pixel, and then we can derive some important quantitative value, like the mean value, the standard deviation, the skewness that represents the symmetry of the curve, and finally the kurtosis that represent the thickness in the right side, in the left side, or in the right side, or the flatness of the curve. So the texture analysis is a quite complex method to analyze the lesion, in which we have to acquire our imaging protocol, then we have to segmentate or recognize the lesion, then we have to extract some features. From all the extracted features, we should choose the most important one, and then we have to compare our results with histological analysis. The final objective of this technique is to identify an imaging signature specific for each tissue, benign one or for different tumor subtypes, or in order to stratify patients and obtaining information related with the final prognosis. Unfortunately, literature, we do not have a high amount of study on liver imaging. The most important one was published in journal Hepatology in 2020, and they analyzed 400, almost 500 surgical resected patients, and they compared the texture analysis results with the microvascular invasion. That seems to be a parameter strictly correlated with the overall survival and with the recurrence of the disease. And they were able to find some specific features that are strictly related with the microvascular invasion. So, moving to the conclusion, today we can say that we have several possibilities to analyze the HCC lesion in the diagnosis and after the treatment, and we can apply a morphological approach that is based on the multi-phase contrastographic study, both with CT and with MR, in which we are able to characterize the lesion according to the brightness and according to the tumor enhancement during the different phases. In this case, we can evaluate the hepatocellular carcinoma with the iyas criteria or with modified RECIST criteria. But today now we are able also to offering several functional information that can be strictly related to the tissue cellularity through the application of DWI sequences that can be expressed as brightness and in quantitative way, or through the perfusion analysis, both with magnetic resonance imaging and with CT imaging. And again, also in this case, we can recognize the lesion to a brightness view, but we can offer quantitative information through the apparent diffusion coefficient with the WI sequences or through the perfusion parameters when we work with functional imaging. And now I would like to thank you for the kind attention, and I would like to thank Professor Hatzidakis for the kind invitation. Thank you, everybody.
I was hoping that you didn't discover this photo of mine you just showed. Okay, thank you very much, Davide, for this great presentation. And it was really very enlightening for all of us. So you mentioned actually the importantness of getting some biomarkers out of pure radiological imaging. So to have some new markers so that we can be able to tell the oncologist also something about the prognosis of his therapy. So this is just a general comment from what I understood. More specific question from me is, you said that after sorafenib treatment, we need a time period until we see the actual result of the therapy, because in the first phase we get some edema, we get some other tissue reactions that might increase ADC, might decrease ADC, so the actual result can be seen later on. Is that correct? And if yes, how long is this time period before we start really understanding if the sorafenib therapy had a positive result or not?
Thank you for the question. Unfortunately, the assessment of sorafenib is the more challenging find for a radiologist, because we have different and several different behavior. So we cannot rely on modified RECIST criteria. So if we use the MRI, we should consider that the perfusion MRI in early phase, so 1 week, 1 month after the treatment, may offer some important characteristics regarding the response to treatment. While if we rely on DWI sequences, we have to wait almost 3 months to obtain an accurate response. So in the same way, I suggest to use perfusion MRI or perfusion CT in the early phase, while diffusion-weighted sequences in the late phase. And if you are more confident with the CT or with the MRI,
we could not hear
the the possibility to use CT perfusion or MRI or DWI depends on the center experience. Some people trust more of DWI sequences, other one are more confident with the CT perfusion. So you should set the time point according to the radiological experience. If you use MRI, you can evaluate the response in the early phase, so 1 month later or 3 months later, because in both of cases you can use contrast agent and DWI sequences with different results and with different behavior.
Thank you. I see Dr. Xinou has a question. If you please unmute yourself and ask the question.
Hello, my name is Katerina Xinou. I'm a radiologist in Theagenio Cancer Hospital. Thank you very much about your excellent presentation. I would like to ask you, because in everyday practice, I would like to know if you perform CT or MR perfusion in order to assess the response to the treatment of in irregular, poorly defined HCC lesions?
Okay, thank you for the question. At the beginning of our experience, we use really a lot the CT perfusion technique because we need some experience and we have to have some training about that. So we use it to perform the diagnosis of HCC, to assess the smallest one. Then we try to apply CT perfusion to TACE or RFA. But till now, after years of experience, we focus our attention or we apply CT perfusion technique only after the sorafenib treatment. Usually we perform the multi-phase CT scan, so an enhanced arterial phase, portal venous phase and delayed. Then we wait for 30 minutes and then we perform a dedicated study with CT perfusion technique. This is our approach with sorafenib. And we do not use anymore for TACE or for RFA, in which we rely more on standard multi-phase study. MR perfusion, it's a little bit more time demanding. We need more time to perform the analysis, and so we do not use too much. And because we are more confident with CT, and so we prefer to use CT to assess the response with sorafenib.
In every case, in everyday practice.
Yes.
Yes, can I please make a question about the first lecture, because I couldn't. I'm allowed, Mr. Hadzidakis, Professor Hadzidakis?
Yeah, sure.
Of course.
Yes. Thank you. We see many times after in the first assessment of treatment response in immunotherapy, we see an excessive progression of disease. We know it as hyperprogression, yes. Do we then need a reevaluation in 4 or 8 weeks, because IRC's criteria don't clear up this topic? Sorry, can I say, and when the patient, of course, is deteriorating clinically?
Okay, I think that you offer me the answer to that question, because in 25% of cases, now we observe the so-called hyperprogression, that is a doubling or increasing of more than 50% of the diameter. Unfortunately, for that case, I think that the clinician has a role that is more important than our role, because they have to decide according to clinical condition if they can continue with the therapy, and then we can wait 4, 6, or 8 weeks for the next assessment. But in most of cases, when we have an hyperprogression, we know that the prognosis of patient is quite unfavorable. So the hyperprogression is the worst possibility that the patient may experience after the immunotherapy.
Thank you very much for your answer.
I think that you agree also in your experience.
Yes, of course. But because IRC's criteria that do not clear this topic, and many of us who may not use IRC's criteria might think that in every progression we wait again for 8 weeks, but this is not the case with fungologists.
Yes. Unfortunately, in the last years, we found the dissociated progression, the hyperprogression, and the pseudoprogression. So day by day, we are finding out something new, and I think that in the next year, in the next 2 years, we will find a new guidelines, an update immunoresist guidelines.
Yes, thank you very much.
Thank you, Katerina. If there is no other questions from the audience, perhaps Professor Prasopoulos would like to have the last word for today.
Actually, there is no need for a last word, because you have presented so beautifully and so explanatory all the possibilities that we have against the question. So The real question now is which road to select, which technique, because it is very difficult to combine all these techniques in everyday practice. But I think, as you already told us, we have to wait to standardize and wait, and probably the experience of each sender may have an influence to the selection process.
Yes, I totally agree with you. It depends on the experience of each radiologist and the technology you have. So the scanner is first.
David, do you think that the new bigger magnets with more Teslas would offer something better than we already have in this manner?
I don't think so. To be honest, I really love CT more than MRI. I think that the next future, the most important application that we could use is the spectral CT, because at once we can obtain information regarding the standard brightness of tissue and tissue enhancement, but we could obtain spectral information dedicated to each different component of each tissues, and we can better differentiate the necrotic portion from viable tissues, especially in oncologic patients. So I think that the next future, the best advice for each colleague is to try to buy one of the spectral scanner, because they will be the future, in my opinion. Okay. More simple to manage than.
And there is a concern I get from younger radiologists or students medical students who would like to follow radiology in the future. They hear a lot about artificial intelligence and texture analysis and all these fantastic perspectives we have, and they are afraid about the future, and if they get busy in the future, or perhaps substituted by robots. And what do you think about that? I think there's nothing to fear, or what's your opinion?
I agree with you, because first of all, we have to study and be confident with our work. And if you remember 15 years ago, 20 years ago, was introduced for the driver, the GPS. And so all the car drivers suppose that they are not useful to find the correct way. But now all of us continue to drive our car, but we use the GPS to find the correct way with the best time, so saving time, money, and stress. And I think that the meaning of applying AI in clinical practice is that one. So radiologists that will work AI will be more efficient than radiologists that will not work with AI. This is my opinion, but we have to wait, I think, almost 5 years more.
Okay, I hope we have another 5 years, despite Corona. And would like to thank everybody. Conclude perhaps for today. Thank you very much for this presentations. I do hope that after next 6 months, we will be able to have you here with us, and perhaps we do another session with another 2 lectures of yours, and this time live in this room. So thank you very much for this, and hope we see each other live very soon. Thank you. Thanks a lot. Have a nice
day. Thank you, everybody. Thank you.
Bye.
Bye.
Thank you very much. Thank you.
Bye.